All right, good afternoon, everybody. My name is Jillian Marchetti, and I am from Homebase, and I'll be moderating this session today along with my coworker, Maddie. I'm going to start sharing my slides so we can get started. All right, so hopefully y'all can see the slides. So welcome to our session, Shelter Innovation, How COVID-19 Changed the Cot. Feel free to introduce yourselves in the chat if you'd like to start to, and we'll be happy to let folks connect with one another through the chat throughout this session. I'm going to take us through a few slides just to set some context and do some introductions for the session before we launch into the content. So today our plan is to, as I said, I'm going to go over a bit of an overview, give us some context for our session, provide some background on non-congregate shelters and how they've particularly been used in really innovative ways during the COVID-19 pandemic. And then we have a panel of a few really great speakers who we're going to ask some questions to and let them share their experience and expertise before we have some time in the second half of the session for a few breakout rooms focused on a few particular topics that we'll introduce in a little bit before we have a final kind of wrap up so that y'all can share some of what you've learned from each other in the breakout rooms and have some final thoughts. So before we get started on the actual content, just a few kind of reminders, tech tips. I'm sure for those of you who have been at the conference for the past few days, you're well familiar, and also many of us are probably more familiar with Zoom than we thought we would be after the last year. So, but just some reminders. You'll be muted during the panel discussion, but obviously when we break up into breakout rooms in the second half of the session, we'll be asking folks to come off mute, and if you're comfortable, to come and put your video on so that we can kind of have some conversations in those breakout rooms. But for the first half, when we're doing introductions and the context and the panel discussion, feel free, like I said, to use the chat to connect with one another. You can put questions in the chat for the panelists if you'd like to, and we'll try to address some of those during the panel itself. And if not, you'll have some opportunities to ask questions of the panelists during the breakout rooms as well. And if you have any tech challenges, you can put those in the chat as well. We've got a really great team on the back end of this helping support the session, and so they'll be able to help you troubleshoot if you have any tech issues. So we're excited to have all of you here. We're excited to have our panelists here to talk about non-congregate shelter. And today what we're overall going to cover in, again, the various ways that I've mentioned already are kind of basic framework for what non-congregate shelter is. And I might be referring to it, or it's on the slides, as NCS as well. And particularly the ways that this model of sheltering can really help promote positive health and housing outcomes for folks experiencing unsheltered homelessness or homelessness who have been able to come into these non-congregate shelter programs. Also to really talk about the potential benefits of using non-congregate shelter as part of your homeless response system, and want to make sure people are familiar with the sort of key components of a successful non-congregate shelter. And again, we'll be talking to some really great panelists who have a lot of experience in this area to go through all of this, as well as some breakout sessions where you'll be able to learn from each other as well. So to the extent that some of you have been working with or around or near non-congregate shelter, especially in the past year plus, but at any point, you'll be able to share with each other as well. So when we start the panel in just a few minutes, I'm going to let the panelists introduce themselves more fully, but I'm just going to do a quick introduction of our panelists and my coworker who's going to help moderate this session, just so folks have a sense before I go through the sort of background slides of non-congregate shelter. So as I mentioned a few times, and I'm sure I will some more, we have a really great, I'm excited about our slate of panelists. So we have Lynnae Altman, who's a public health program specialist at Contra Costa County Healthcare for the Homeless. We have Dr. Josh Bamberger from San Francisco, who led the San Francisco Department of Public Health's Housing and Health System of Care for many, many years, and is currently a primary care physician, but has sort of returned to the San Francisco Health Department to help with the serving of people experiencing homelessness that were impacted by the pandemic. And then we also have Jenny Lynn Holmes, who's the Chief Program Officer for Cafeterias in Santa Rosa and Sonoma County. So those are our primary panelists we'll be hearing from when we open up for our panel discussion. We may have an additional panelist when the time comes. We'll find out. we might have some exciting special guests join us as well. But we're excited to have these three panelists to talk about their experiences and share lessons with all of us. I introduced myself briefly at the beginning, but as I said, my name is Jillian Marchetti. I work for a nonprofit called Homebase. We do work all around California and the country, helping build community capacity and working with communities on their responses to homelessness. And I personally have been working on a lot of COVID response TA over the last year and a half of technical assistance through HUD, including working with a couple communities on their non-congregate sheltering that they've set up as part of their COVID response, and also their rehousing efforts from folks who are in non-congregate shelter, working to get folks rehoused. And I'm also joined by my colleague, Maddie Nation, also from Homebase, who's going to be helping help put this together. Thanks, Maddie. There she is waving. Actually, why don't I let Maddie introduce herself before I go on to the rest of the slides.
Hi, I'm Maddie Nation. I'm a policy analyst with Homebase. My interest in this work comes with my extensive work with our peer communities effort, which is a grouping of semi-rural and rural communities across California, talking about how they're responding to the dual impacts of COVID-19 and homelessness. So we've talked a lot about non-congregate shelter, and like Jillian, I am super excited for this panel. We've got great folks here today.
Thanks, Maddie. And as I said, I know I haven't let our panelists introduce themselves yet, but we'll get to that in a few minutes when we actually start the panel. I'll have them introduce themselves and give a little more detail about their work in this area. So I'm just going to spend a few minutes giving a little bit of background about the non-congregate shelter as a particular kind of temporary shelter that we've seen really spring up a lot in the context of COVID-19 response over the last year plus. So I'm sure, folks on this call are extremely familiar with all kinds of different temporary shelters, from the sort of what a lot of people, especially who don't necessarily do this work, think of as a sort of traditional emergency shelter, which is, often congregate shelter. And of course, over the years, there have been lots of different kinds of shelter models that have been used in different communities around the state and around the country. So we've had some of them here, but today we're really going to be focused specifically on the ways that hotels and motels, especially over the past year, or past 15 months, have been used as a form of non-congregate shelter in the context of COVID response. So before we go over a little bit of details about what non-congregate shelter has looked like, especially in California over the last year to 15 months, we do want to get a sense from folks who are in the room right now, what your experience is with non-congregate shelter, or your familiarity with the term. So if we could launch that poll, please. All right, and while we're getting the poll set up, I just want to remind folks that you're welcome to chat. And oh, great, thanks. So hopefully you're seeing the poll question. How would you categorize your experience with the term non-congregate shelter? So we'll leave this open for a minute to let people take a look at the options and select one. I've never heard of non-congregate shelter. I've heard about non-congregate shelter.
I've never heard of a non-congregate shelter, CAC.
I've occasionally heard of non-congregate shelter and vaguely know what it is, but couldn't necessarily provide a definition. That you're quite familiar with non-congregate shelter and can provide a definition, or you've lived and or worked in a non-congregate shelter. So if we can give folks maybe like 30 more seconds to fill it out, it'll be good to know what the experiences of the folks that are joining us on this session today. Great, maybe just 10 more seconds and then we can close it and share the results. That'd be great. All right, great, thanks. Okay, so great, we've got a mix of folks, some who have never heard of non-congregate shelter. Happy to have you here to learn about it. And then a sort of combination of folks who have maybe some varying familiarity with it, and even some folks who have lived or worked in it. So that's great. I'm really glad to see a combination of, or a variety of folks on the call.
Sorry, sweetie.
Thanks so much for filling that out. All right, so it seems like for some folks this will be maybe a little bit more of a refresher, and for some folks this might be some new information, but just to have a couple slides before we open it up for panel to set the context a bit. So again, there have certainly been non-congregate shelters in different communities for various reasons before COVID-19, but we're particularly talking about non-congregate shelter. We're using the last year, 15 months as sort of some context to talk about it, because this was the first time in the context of the COVID-19 pandemic that a lot of communities across the country, and especially in California, really use non-congregate shelter as part of their overall community's emergency health response to help prevent and mitigate the spread of COVID-19. And so, for example, so this isn't not all non-congregate shelters, of course, were part of California's Project Room Key, but we wanted to use it as an example for this conference, and hopefully a lot of folks have at least some familiarity with Room Key. But it was a project that started in March of 2020, so right towards the beginning of the pandemic, as part of the state of California's COVID-19 emergency response. And what it provided was funding to allow communities to open up non-congregate shelter in hotels, specifically for folks experiencing homelessness, people who wouldn't otherwise have a place to safely shelter in place. And while eligibility in the specific programs vary by location, a lot of communities prioritized individuals to come into those shelters that had either tested positive for COVID-19 and so needed a place to safely quarantine and possibly get some healthcare while they had COVID-19. For folks who had maybe been at least exposed for COVID-19 and again didn't have a place to otherwise safely shelter in place or isolate from others, or people who were at higher risk for COVID-19 health complications or severe COVID-19 disease. So folks who were older, folks who had the underlying conditions that put people at particular risk for having severe COVID-19 if they were to contract it. So between March 2020, when the program opened, and as of April 2021, at least we have the information that there were approximately 36,000 participants served via the different Project Room Key non-congregate shelter programs around the state. So again, we just want to emphasize that this was a bit of an unprecedented use of non-congregate shelter, and particularly in hotels and motels. And while it was part of the public health response, it has a lot of other lasting impacts that we're going to talk about today, or some other benefits and challenges, of course, but benefits for folks who are experiencing homelessness and we're in this really unique type of shelter. So we'll talk through kind of what that means as far as impacts for both the individuals in the shelters as well as the programs and systems that we're working with them. And so again, just the final thing before we open it up to the panelists and hear directly from the folks we have lined up, just wanted to lay out a few common attributes that made it particularly interesting in this context of COVID-19 response. So again, unlike traditional congregate shelters, right? Every individual or household who was coming into these motels as part of their sheltering had their own private space, which included a restroom, which is of course not necessarily not part of congregate shelter, of course, but also not necessarily part of other types of non-congregate sheltering. So the hotels or motels were really specific and unique in that way. Relevant shelter in place orders or COVID-19 protocols in whatever community the hotels were in were often applied. So for example, folks were actually in their rooms or meant to be in their rooms a lot, in the same way that folks were being asked to stay in their homes. Folks who had their own homes were asked to stay in. So it was so folks were kind of in the same room in the same place in a way that a lot of folks who came into these shelters hadn't previously been able to be. And then because it was part of COVID-19 response, of course, there was varying on community and site connection to public health nurses or other health providers, including on-site sometimes. And then often, again, because folks were being asked to shelter in place and stay in their rooms, most of these programs also offered some sort of food assistance or meal delivery. So now I'm going to hand it over to our panelists, or I'm going to stop sharing my screen because I want us to be able to actually see and hear from our panelists. So just give me 1 sec to do that. But we're going to hear specifically, we're focusing on the health, rehousing, health and rehousing benefits, or the impacts on health and rehousing ability for folks that came into shelters, and also the ways that these non-congregate shelters have had impacts or been able to better serve folks in particularly vulnerable populations. So with that, I am going to have each of our panelists introduce themselves. Again, I gave a little brief intro, but I'm going to go one by one and have them introduce themselves. So I'm just going to start with you, Lynnae. So if you could each, as I go one by one, if you could state your name, your pronouns, your organization, and then your kind of relationship to or your experience with non-congregate shelter, and then we'll get into the fun questions after that. But I think it'd be great for everyone to hear from each of you on those bits.
Hi everyone, my name's Lynnae Altman, and I identify as she, her, and I work with our Contra Costa Health Services Public Health Department, and specifically with our Healthcare for the Homeless program. I serve as kind of our liaison between our Public Health Department and our homeless services throughout the county, including our Health, Housing, and Homeless Division that's also within Contra Costa Health Services. I have been working since the beginning of the pandemic on moving people out of our shelters and our congregate settings into our non-congregate settings, and then providing all of our medical and behavioral health services at those sites. So coordinating the move of those individuals into our Project Room Key sites and the non-congregate sites, as well as making sure that we had all the services in place as those sites continue to operate at this time. So I'm excited to be here and excited to continue the conversation.
Great, thanks so much, Lynnae. All right, Josh, would you mind going next, introducing yourself and your kind of experience or connection to non-congregate shelter?
Sure. Good afternoon, everybody. My name is Josh Bamberger. I use he, him pronouns. I am a family physician, and I have been serving people experiencing homelessness in San Francisco since about 1990. As of March 15th of this year, I started screening people in congregate shelters for signs and symptoms of COVID-19, and then proceeded to help folks move into our Project Room Key hotels and supervise the medical and behavioral health services that have been provided in those sites since we opened our first site in about April. So it's been about a year and a half now. And in addition to that, I'm a primary care physician at the VA, where I take care of homeless veterans, and I'm on faculty at UCSF. And thanks so much for including me.
Great, thanks, Josh. Thanks for being here. All right, Jenny Lynn, could you introduce yourself? And
hi, yeah, my name is Jenny Lynn Holmes. I'm the Chief Program Officer for Cafeterias and identify as she, her. And I oversaw multiple non-congregate shelters during the early times of the pandemic and throughout. 3 of them were operated out of different hotels, one of them at our local university. And then we also did a kind of not typical non-congregate shelter through our Finley Safe Social Distancing site, where we actually set up a tent type structure to allow for social distancing and medical care on site. So I think that's what we'll primarily be talking about today. We were the operator, so we ran all of the operations at all of the sites and also coordinated medical care and on-site services for people. So that was my big role. Thank you.
great, thanks, Jenny, and happy to have you here too. And then I mentioned we might have a 4th panelist that unfortunately wasn't on the slides, but we're really happy to have them here. So I'll ask, hopefully I'm not putting them on the spot too much, but Nita, would you mind, from the village in Alameda, would you mind coming on and introducing yourself and your connection to non-congregate shelter, your experience with non-congregate shelters?
Yeah, I'm having a problem with my video. It won't turn on the video.
Oh, sorry, we can hear you okay.
Oh, my name's Nita, Nita B. I'm the founder and the interim executive director of the village in Oakland. I'm unhoused myself. I've been working with unhoused populations since the early 90s here in Oakland, California, primarily youth during the 90s and 2000. And now in the millennium, dealing with this new phase of homelessness that has improved because of gentrification. I've been in congregate shelters myself as an unhoused woman. And during the pandemic, we started a shelter program through the village. Actually, we started a coalition before the congregate shelter to pressure the governor and our individual mayors to use the hotels. And out of that campaign is where Project Room Key came out of. The depending on what city was doing it. It was a call put out by, I believe it was Coalition on Homelessness in San Francisco put out the call. Here in Oakland, the Village, East Oakland Collective, and Living Justice in the Street responded to the calls. People in Sacramento responded, Fresno, San Francisco, San Diego, Riverside, and Los Angeles. In those cities, we each had our own campaigns to get this hotel program up and started throughout California. The name of our program here, and because there was no movement for almost 2 months here in Oakland, we started a hotel program in April. The hotel program here in Oakland did not start till towards the end of April, beginning of May, in terms of Project Home Key. And the name of our program was Hotels Not Graves, with the idea we needed people in hotels, not in graves. And if we put people in the congregate shelters, more than likely during COVID, they would end up in graves because of how this pandemic appeared to be spreading.
Oh, thanks so much, Nita. Glad you're able to be here with us. So I am, again, thrilled that we have our 4 panelists. We're going to go through a series of questions with our panelists, hear from all of them on a few different questions before we then, in the second half of the session, are able to break out. In our breakout sessions, our panelists have graciously agreed to be part of them as well. So you'll be able to kind of ask some follow-up questions of them too. If you have questions for our panelists, feel free to put them in the chat. And then you'll be able to have some time to ask them specific questions during breakouts too. So I'm going to open this up, and this question I'll ask to all 4 of you. So anyone who wants to go first can. But the first question, and if you're not a panelist, if you could mute yourself, I think we're hearing some background noise. That would be great. So our first question for the panelists is, from your perspective, and I know you've all have differing experiences with non-congregate shelter, what has been the greatest benefit that you've seen of these non-congregate shelter models, specifically over congregate shelter?
I can go first if you'd like, or one of us has to go, I guess. So I'll quickly just mention, just to give an overview of what we do. Cafeterias operates primarily in Sonoma County, Napa County, and Lake and Mendocino, but our biggest shelters and services for the homeless are in Sonoma County. So we operated several non-congregate shelter sites, both traditional and non-traditional, so some through the hotels, and then one through our safe social distance site, which was tents set up in a socially distanced and safe way. I would say, originally the concept of our non-congregate shelters was to protect individuals from contracting COVID-19, especially those that were at high risk. And so we targeted predominantly the people with the pre-existing conditions that were found to be more harmful and more serious issues happening. And then for our safe social distancing site, which was about 64 tents that we set up in a socially distanced way, that was more to alleviate some of the pressure in our encampments and provide an alternative for people to come in and be able to be in a way that was actually socially distanced. Now, there were a lot of health benefits in our entire operation of all of our non-congregate shelters. We only had 1 COVID positive case, and it remained at 1. There was no additional exposure that happened in the sites because of the way they were kept. We were able to provide on-site medical care, access to care in ways that they were not able to get. We were also able to get testing on a regular basis, and when vaccinations were happening, we were able to bring it to the people and where they were staying. But there was a larger kind of health impact that we saw too, outside of kind of the traditional, what we started this to be, which was helping people protect themselves against COVID-19 and contracting it. But we also saw a significant increase in predominantly women coming in, feeling the safety of the site, escaping harmful situations that they were potentially living in, whether it was in a survival sex situation, escaping human trafficking, domestic violence situations, and so on and so forth. So there's this additional health impact for individuals to not only get their access to care, but also outside of just the physical health, some of the other dangerous situations that many of them were living in. We found that they sought refuge with us and allowed them to get access to care, and also allowed our outreach workers to know where individuals were. So we were then able to get them to their medical appointments. We were able to get them going through the document readiness process to housing. All of those things that our outreach workers spent half their time trying to find people across the county. We knew where they were. And so it really helped us enhance the care for them as well. So that would be an additional piece I would talk about.
Thanks, Jenny Lynn. Josh, I think you came off mute around the time Jenny Lynn did. Did you want to share as
Sure.
well?
Thanks. So this has been, one of the most impactful experiences of my 30-year career to prove the concept that we can house thousands of people quickly. So for so many years, politicians and policymakers have used the excuse that it's impossible to have enough housing stock or to move people quickly into housing, or that homeless people experiencing homelessness want to move indoors. So all those myths have been slayed as we've been able to bring in San Francisco 2,300 people indoors in a 6 to 8 month period into decent housing with their own bathrooms and their own safety. So that's probably the most important thing going forward, to prove the concept that yes, we can, if we want to, do what we all should do in the first place, which is to give people a home. So that's, can't be understated. Secondly, this has been an extraordinary natural experiment for a physician to be able to have so many people who are almost randomly assigned to housing. And we have been able to provide a medical evaluation for each and every one of them that have come into housing. So we have a better sense than ever before as to the medical needs of a large population of people experiencing homelessness. And that gives us also extraordinary amounts of information on how to design and prioritize our limited resources for medical care going forward. So those are two really important and unprecedented things that have happened. And then finally, we've found that bringing people into homes as opposed to staying on the streets saves their lives. So I'll share some data with you in a bit, showing that the mortality rate among people who we've housed over these last 18 months is dramatically less than people who have stayed on the streets during this COVID time. I'll stop there. Thanks.
Thanks, Josh. Lynnae or Anita, did either of you want to add anything as far as the greatest benefits you've seen from non-congregate shelters compared to congregate?
Yeah, I mean, I can just definitely echo both of what Jenny Lynn and Josh have already said. We're seeing the same thing here in our county. We are definitely seeing a benefit of getting people indoors. We historically, in our shelter settings here in Contra Costa County, are very congregate settings and have seen a lot of barriers to people wanting to join those congregate settings. And therefore, the individual rooms and being able to have their own bathroom, especially those who are a very high acuity, have actually been a huge benefit to get them into those spaces and be able to have that private space and also access to a restroom in close quarters. So that's one thing that we noticed a lot, is for our individuals who have a lot of health impacts, that personal space is really important for them, as well as hygiene in the sense of wound care, things like that. Having that personal restroom and hygiene services right within their room has been a huge benefit, and has helped people recover quicker from some of those long chronic conditions. We also have seen our staff have been able to reach everyone. So moving people into these sites, we kind of had a target of giving everybody initial behavioral health and medical visit, which, as Josh said, it allowed us to kind of get an understanding of what people are coming into these sites and what kind of health impacts or health issues and chronic morbidities are they bringing with them, and then being able to provide our services to these people multiple times a week, and allowing them to have access to us as a walk-in basis and multiple times a week has shown to improve a lot of our clinical measures, one especially being diabetes. A lot of our poor rate in our diabetes, like our controlled diabetes, was a lot of missing A1C reports, things like that, missing those scores. And we've seen a dramatic increase of actually capturing that data and then seeing a dramatic decrease in the uncontrolled rates, which is pretty awesome. So that's just a couple things, and I'll, again, share some more data later. But.
Thanks, Lynnae. Nita, I'm glad you're able to join on camera. Do you have anything that you'd like to add as far as what you see as the sort of major benefits of being able to offer non-congregate shelter to folks?
Yeah, I would first say that I agree with what has already been presented and shared. And to add to that, I think what we saw was a decline in mental health issues, including addiction and dependency. Just having that stability, that sense of normalcy of being in a hotel, and all the hotels we used had kitchens in them. So they were actually like really studio apartments. But just seeing that sense of normalcy happen and people being able to stop using a lot or stop using completely was huge. And then also to see people realize that life on the streets, that they were done with it. Like I think, you know, there's this to be on the streets, to cope with living on the streets, you kind of have to accept it and make it to be not as bad as it actually is. But I think with having the normalcy of having a place to lock it, take a shower, cook a meal, started, you know, impacting people where they're like, you know what, I don't want to go back. Good. Let's figure out how to keep you off the streets now. So I think that was the huge mental health shift.
Thanks, Nita. Yeah, I really appreciate you all kind of sharing some overlapping, but also like really offering unique, a lot of different benefits that you all were able to cover. So I appreciate that. One, I think there's always a tendency when there's a relatively newer or something that more folks are trying out to really focus on the benefits, which is great. But I also think it's important to kind of be honest with each other and others too that aren't necessarily there with us. So I also want to ask about kind of what you've seen as the biggest challenges with this model. And we don't have, you know, I'm open to any or all of you answering this question if anyone wants to share kind of what have been the kind of key challenges in operating a non-congregate shelter model.
I'll jump in quickly. I mean, the biggest issue is around how people use opiates. So for years, people would share opiates and use together. And then when they were forced to go into individual rooms, there was often people were using it by themselves. So at least initially, we had a big increase in opiate overdose deaths among people who were moved indoors. And I think we have to be aware that the homeostasis of how people use and obtain drugs is well established. And when something's disruptive, like having to move into individual homes, there are unexpected outcomes. So the worst bad thing that has happened is the large number of people who initially at least had bad outcomes from their ongoing addiction.
Thanks, Josh.
Yeah, I can just follow up on that. That was the one challenge that I've definitely highlighted here and that we've seen. One thing that we've been working to kind of against this is offering Narcan and making sure it's readily available to the patients, because we do see that they are unaware that it's available. We don't want them to have to ask for it, things like that. So we're really trying to make that available, but that is one of the largest challenges we're still actually struggling with, because in a congregate setting, everyone kind of has eyes. You can see everything and everyone kind of can see everybody's stuff. It's very different than in this hotel model. And for Contra Costa County, this is actually very new for us. I know some other counties, this is something that they've done in the past, but this is very new for us. One of our Project Room Key sites that we've actually turned into a site moving forward is actually managed by one of our Bay Area community services, one of the partners here that works in Alameda as well. And they've done this kind of model in other counties, but not ours. But so this is new for Contra Costa County, and this is something that we're trying to learn as much from all of you and from everybody who's here at this meeting and conference to kind of work on how we can help mitigate some of these concerns.
I would add just a couple of quick things. One, as I mentioned, I think I have an atypical, one of our sites was atypical in that we were in an actual hotel. We were actually tents that we set up in a safe, socially distanced way. So our biggest challenge, honestly, was weather. So as you can imagine, so we're looking at potentially, what we really enjoyed about it was it added an alternative in our system of care for people who maybe traditional shelter or something along those lines, that doesn't work for them and they need more of their own space, or they're still in the transition place of not sure what their next step is. At one point, our site, more than half of the people that were there had never entered a service before in their entire history, being homeless. So it was a great way to provide a new alternative, but not with the tents. The weather was a real big challenge for us. And also we had, every kind of weather we had. The other challenge we had was neighborhood concerns and cry outs. And that's pretty typical in our industry, I would say. But we hosted a community meeting at the beginning, and then we hosted a community meeting at the end. Once we were able to lay out our management plan, our security plan, we integrated the individuals that were living there into the community. We actually paid stipends, and they helped do cleanups in that part of our town. By the end of it, we had neighbors saying they can stay there all year long if they want. So it's always an issue, but what I always say is reach out to those of us that have done it before, and we can help talk to that community and explain that it doesn't create the issues that people perceive or think happen when you have good management plans, and you have the input of the people who are living there, and you have their participation. Most of those concerns don't become a thing, and those neighbors actually ultimately, many of them became our volunteers and donors. So but that's definitely a challenge. Anytime you do something new and you do something in a different part of the community, it's usually something that comes up.
Thanks, Jalen. Oh yeah, go ahead.
Yeah, I'd say the two challenges that we had, actually three. One, so we really believe, like, one of our fundamental principles that we work with in the village is that in order to receive help, you have to be willing to help yourself. We do that with our villages. We do that with any of the programs that we run. And that was just something that came up in the congregate shelters, is that folks weren't really interested in utilizing this. So, not everybody, a small handful of folks were not really utilizing this as an opportunity to kind of get their mind straight and to kind of rethink how they're going to stay out the streets, what are their future goals. They really utilize this as an opportunity to pimp, for lack of a better word. And because we had really low barriers, and we actually expanded what our definition of vulnerable was. So it was bigger than the definition for home key. But folks really saw this as, some folks saw this as an opportunity to try to get over and get a free room and to do a bunch of stuff that they had no business doing. And related to that was having folks adhere to the idea that this was a shelter-in-place program. I think that was a little difficult for folks because people are so used to having there's a freedom you have living out on the streets, and which is part of the freedom that gets in people's way when they've been chronically homeless to maintain permanent housing, is this love of the freedom of the streets. And so we were dealing with that in a shelter-in-place program, where folks were like, what do you mean I can't have parties? What do you mean I can't have people over? It's like, it's a shelter in place. This isn't just a regular hotel voucher program. This is to stop the spread of COVID. And I think the third kind of challenge we had, and I've heard from some of our folks who worked with the Project Room Key program, that they were having the same challenge. There was no permanent housing or long-term transitional housing attached to this program. So when the funding ran out, everybody was freaking out. The service providers were freaking out. The folks living in the hotels were freaking out. So I think that's something to think about for the future of when we have these, whatever the situation is that allows us to house this many people temporarily. What is the exit plan? There has to be an exit plan. We cannot be exiting people without a plan, just to return them back to the streets.
Thanks, Nina. That's a really good. I mentioned at the start of this that one of the three kind of key topics we wanted to talk about for this was housing, and like to the extent that these non-congregate shelter programs have been able to help response systems or programs help exit folks into housing. So we will get to that. I'm going to circle us back to that in a second. Before we move on to that, though, I want to ask, and again, this can be a bunch of you or a few of you mentioned specifically when you were first answering the question about just the biggest benefits of non-congregate shelter, brought up different kinds of benefits that you saw with connecting folks to healthcare, health outcomes. So I wanted to, so some of you have covered this a bit, but I wanted to ask if folks had any other specific information they wanted to share in terms of like the benefits of connecting folks that were staying in non-congregate shelter to health. And I know, Josh, you had some slides that I can share so people can see. So we could start with you. If you wanted to go over some of that, give me 1 second, I will share it. And then I can also, curious to hear from the rest of you if you'd like to add anything. So let me just, Josh, I'm just going to pull up your slides real quick.
Okay.
And you can just, tell me to advance them.
So just really want to briefly go over this extraordinary investment that has happened in San Francisco. So, over a 6-month period, we opened up 23 tourist hotels with 2,300 people that we've housed. People were prioritized if they met COVID vulnerability criteria, including being over the age of 60. But we were able to have a medical staff in each one of these hotels so that everybody who came in was seen by a nurse or nurse practitioner at least once, and then often many times throughout their stay. And one very important takeaway that I think is actually kind of shocking even to me, having done this for so many years, is the relatively low percentage of people who were regularly using the on-site nursing and who had a medical condition that we clinically felt would deteriorate if they didn't have a nurse on site. So this is very important going forward as we try to pivot from our shelter-in-place hotels to our permanent supportive housing. We believe that only about 6 to 7% of the people who we've housed really need to be in a site that either has an on-site nurse there weekly or available to them on an as-needed basis to be able to successfully stay housed. Now that's a lot less than I think most people in the general population would think. So that was one very important takeaway. If you go on to the next slide, please, Joanne. Then the other thing that we found is how much the utilization of healthcare dropped after we housed people. So for folks who are on the streets or in shelter in the 6 months, and this is data that comes from Elizabeth Abbs and Naomi Schoenfeld, two researchers at UCSF and their colleagues, we found that we did a randomized study of the 2,300 people, looking at 400 of these folks, and they averaged about 2 emergency department visits a year in the 6 months, prior to moving in, and then afterwards it dropped to about half a visit per person. So that's a really dramatic reduction across a large population. If you want to cost that out, you'd finally reach that holy grail of the research I've been doing all the years, which is to show that it's less expensive to be housed than in the shelter or on the streets because of the healthcare savings. And the last slide is probably, let's move on to the next one. The last slide, which is probably the most important slide. I'm sorry, it's really small, but I'll walk you through it. This is new data that comes from Barry Zevin, Dr. Barry Zevin in the medical examiner's office in San Francisco. It's really dramatic and important. So I'm going to walk you through it briefly. The blue line, which is in the center, is the mortality numbers of people experiencing homelessness in 2019. And if you can zoom in on that and have better eyes than I, it's something like 148 people died in 2019 among people experiencing homelessness. Since COVID hit, which is in March of 2020, you see the red line, which is the deaths for 2020 and then going on until March of 2021. You see this inflection point where the death rate was about the same before COVID hit, and then this huge increase, almost a doubling of death rate among people experiencing homelessness in San Francisco, so that you had, by the end of 2020, almost exactly double the number of people died on the streets than in the previous year. And almost all of those deaths are attributed to overdose from fentanyl. So while almost no people experiencing homelessness have died from the direct impact of the virus on their health, many people more have died because of the disruption in their life and the introduction of fentanyl into the community. And then the last bar on the bottom is the number of deaths among people who moved into the shelter-in-place hotels. And if you remember, these are people who are sicker than the average bear. So we went out of our way to find people who were medically frail. And yet the death rate among those people was actually less than the death rate that was seen in 2019. So just to summarize that with some simple ways to think about it, unfortunately, about 1 of every 20 people experiencing homelessness will die every year on the streets, a 5% death rate. However, if you move them into a shelter-in-place hotel, and I would say into permanent supportive housing, 1 of every 50 will die. That is a dramatic reduction in mortality that can probably not be seen with any other intervention that I have in my black bag. Nothing around vaccines, nothing around penicillin, nothing around chemotherapy, nothing around hypertension medications, nothing will reduce death on a population basis as we've been able to show through this remarkable intervention of housing, which should be a human right and just happens to be good medicine. So I'll kick it back to you, John.
Thanks very much. Appreciate you sharing that information. Yeah, wow. That last slide, I know you said it was kind of hard to see, but even the difference is so stark that even in that small kind of fun. You can see like how dramatically that decreases. So really appreciate you sharing that. Lynnae or Nita or Jenny Lynn, do any of you want to share a little bit more detail, whether you've been able to track it in the same way that Josh was able to share or not, like more, anything more to share as far as like health benefits that you've seen and been able to track for folks who have come into these non-congregate shelters?
Yeah, we also were able to have a dedicated mental health and a dedicated medical health, physical health person come. And so folks were able to get assessed when they came in. They were able to get to their appointments if they had to go off-site to go see a specialist. A few of our folks were denied, while they were living on the streets, they were denied life-saving surgeries. That's a common thing where if folks can't prove that they're going to be released into some kind of stable housing, then they're denied surgeries that could save their lives. And so 2 of our residents were able to get these surgeries that they've been waiting to get for years because they were going to be released into the hotels. So that was huge. But yeah, I think having not just the medical health, but just all wraparound services located in one area just helps everybody. It helps all the service practitioners because we're all in communication with each other. And then people know exactly where folks are. I heard somebody say that it was really, it's difficult to find our folks that we're working with when they're on the streets because they could float around, they could get evicted, anything could happen. But when we had everyone centralized, that just kind of helped the overall wellness of people and their access to resources and services that they need.
Thanks, Nita. And Lynnae and Jenny Lynn, I know both of you during your initial remarks brought up a couple of health benefits, so feel free to leave it at that, or if you had more to share, welcome to.
The only thing I would add, I ditto everything that's been said, but we also tracked kind of police calls for service and medical calls for service. And we saw a reduction when we have management and care on site, because we had a mobile medical unit that was partnership through our local hospital, Providence Memorial Hospital. They have a mobile medical unit that was coming onto our site several times a week so that they could get their care. So something else we tracked, especially for the community perception, and we saw a reduction among the population around both police calls for service and fire calls for service. So not directly health on the individual, but community impact, that those resources are better utilized. And there's lots of studies that show that, but it was a kind of more local study that showed that the community impact is also great.
Yeah, thanks, Jenny Lynn, absolutely.
I wanted to say one other quick thing, so it doesn't sound like a contradiction. We did have a very high increase of overdose deaths in the first 2 months of people when they moved into shelter-in-place hotels. But then we literally taped Narcan on the walls of every hotel. So in between each room was taped Narcan, naloxone. And we had a wonderful group of harm reduction specialists who came in, who provided people with naloxone as well as information about how to prevent death from opiate overdose. And then we started a new Suboxone or buprenorphine starts in a very aggressive way across the entire system. So we have about 200 people who we initiated Suboxone starts on. And those 2 interventions plus the education really flattened out the death curve. So initially it started high, but then it flattened out to even pre-2019 area. So don't want to sound like I was talking on both sides of my mouth, that there was an increase of overdose and then a decrease, because there actually was both.
Yeah, thanks for clarifying, Josh.
Yeah, I mean, I can add, I kind of mentioned earlier that we kind of took advantage of having a lot of these individuals at our fingertips. Also, one thing that has allowed our Healthcare for the Homeless team to do is really focus on providing services at these sites, and then as well as our outreach teams out in the community. So our outreach team partnered with our street medicine team, partnered with our outreach teams to really get people indoors. And like I said earlier, a huge benefit was getting people into separate rooms. So a lot of those people who historically did not want to go inside, didn't want to do that congregate setting, we ended up being able to get them into this hotel setting. And then we've actually seen a lot of success in some of these longtime homeless individuals, getting them into housing even from these hotels. So I think the hotels offer a huge benefit of health benefits, but also of people's willingness to get inside. And then while they are inside, our health team has been able to provide a lot of services directly to the patients and get them connected to care prior to being housed. So they have that care set up and are able to get the resources and the supplies that they need wherever they're going next and into those housing placements. We were able to focus on a lot of the chronic disease management while we've been in these hotels for so long, which has been really great. Historically, those who are living on the street, that's really hard. As Jenny Lynn mentioned earlier, going to try to find these people and following up with these people in the streets can be a huge challenge. So getting them indoors, really, we saw a huge decrease in some of our uncontrolled diabetes rates, which was really exciting. Also in some of our cancer screening rates, which was great. We also have seen a huge difference in our vaccinations within the hotel population. So because the clients are there and we were able to bring the vaccine directly to them multiple times throughout this whole process and continue to do it on an as-needed basis for these clients, we saw 63% of our hotel population is fully vaccinated. And then of our full HUD population outside of our hotels, it's only roughly 32%. So we did see that helped. And we also saw that with our flu vaccinations when we started doing that at the end of last year, or fall of last year as well, that our flu vaccination and immunization rates increased greatly among that population as well. Because historically, we don't see a great immunization rate among our homeless population. So that's some of the benefits that we definitely saw, and look forward to keep increasing and keep getting better.
Thanks.
Thank you, Josh, for sharing kind of what you guys have done with the Narcan, because I think that everyone is probably experiencing that same thing. So it's great to hear what you guys are doing there.
Thanks, Lynn. Yeah, and Lynnae, your point about them or your vaccines, and I think Jenny Lynn, that might have been you earlier that mentioned vaccines as well. And I've seen that in other communities as well. It's interesting. It's like not surprising. Like imagine we talk all the time about how important it is to bring services and bring connections to folks where they're at. It's amazing how much easier that is when where they're at is a stable place to stay, right? So it's good that we've kind of seen that consistently in a lot of these different programs. So I want to switch a little bit, and Lynnae, you spoke to getting folks connected to healthcare and other services sort of on their way to exiting maybe to more permanent housing from non-congregate shelter. So I do want to switch to focus a little bit more on that housing piece. Nita mentioned that one of the challenges with at least like Room Key or the funding that was specifically for these non-congregate shelters is that it was funding for the shelters themselves. And at least that funding wasn't also didn't necessarily come with, you come in a shelter and automatically you get a housing resource to exit to or for an exit plan. But of course there has been either through Project Home Key, which is sort of the companion follow-up from the state, and as well as some federal funds that have come through. There have been some additional housing resources opened up as part of the COVID response in the state and across the country. So would love to hear from y'all if you could share some of the ways in which having folks in non-congregate shelter with the operations of this shelter, how it has helped connect people, or how you've been able to connect people that were staying in the hotels into more permanent housing placements. Jenny Lynn, you're nodding. Do you want to start?
Yeah, I mean, with our operations at both the kind of more traditional hotel non-congregate shelter and then our kind of non-traditional non-congregate shelter, one of the things that was most helpful for us was the document readiness process. We all know that's a huge push, especially when we're working with people who have been homeless for an extended period of time. And the document readiness process, we were able to get people document ready much faster than we've ever been able to do, particularly among individuals who typically live in our unsheltered population. So when we were working on transitioning down these sites, we were able to give people the opportunity to enter one of our other shelters. And luckily, all the progress they made with our outreach team then continued on to their shelter case management team. So that was probably one of the most helpful things for us. We were able to place many people directly into permanent housing, but our Findlay site was only open for about 6 months. So it wasn't necessarily long enough to kind of see through, because of the population we were dealing there were people on average there had been unsheltered for several years. So we were dealing with a much more vulnerable population and can typically get housed in that short of time. So many of them are continuing on with that pathway now in our other shelter settings. But the document readiness process was huge, because trying to get someone to get to the DMV, to then get to the Social Security office, to then get back to the DMV, to then go get their, birth certificate at our other county building, like, is a tremendous push, especially, and it's even harder when you don't know where they're going to be the next day. But we knew where they were going to be. We could make an appointment. We'll pick you up at 8 a.m. We know you're going to be at this site. We'll be there. So we were able to fast track that process in a way we've not been able to do since. So, yeah.
Thanks, Jennifer. Lynnae or Nita or Josh, I feel like you gave me the heads up that you'd probably be talking more about the health piece. So I don't want to put you on the spot for the housing, but obviously if you have anything to share, well, you're welcome to. I do, Jenny, I do appreciate you mentioning specifically like the ways in which I think we talk a lot about the benefits to folks staying in the shelters, but I think some of what you just described in terms of helping people to get doc ready and to get to appointments is also, it's good to think about the ways that it benefits the programs that are working with clients, right, as well, because it makes things, simpler and a lot easier for staff that are working with folks as well.
Yeah, and the people we served were not people who would traditionally go into a shelter. They're people who maybe their mental health precludes them on their own personal choice, or, the feeling they're, of a congregate living shelter. That was who we were predominantly working with, was people who, even put COVID aside, in a normal life setting, would not enter shelter. So this was a chance for us to capture a population that had been really hard to get housing and doc ready. And that was a significant shift for us. And we had people who were afraid to go into our congregate shelter. We've seen since vaccinations have come into play for the population, we've seen our shelter usage rate skyrocket, because now people are feeling comfortable to come back into shelter. But at that point, they were not. So this was an alternative for people that typically wouldn't go through these types of services. So that was why our focus was to get as many document ready as we could. And get as many housed as we could. But unfortunately, the people we were working with had been unhoused for so long that 6 months was just not enough turnaround given our housing market.
I'd say that, it was a challenge we just had an agreement amongst ourselves, amongst our organization and with the residents themselves, that we were not going to exit anybody back on the streets if they didn't want to go back on the streets. That we really were trying to let folks use this as an opportunity to get on with their lives and to improve their situation. And we were able, it was crazy because there just isn't affordable housing stock in Oakland anymore. It's not just affordability, it's qualifying for it. Like I myself, I've had a 30-year catering business, a very successful catering business here in Oakland, still have it. I've been able to put 3 children through college. I cannot afford to live in Oakland. I don't qualify to live in any residence in Oakland because of these new standards they have for the new Oakland. And so these are the barriers that we had 47 households we had housed. And so we had to deal with a different set of barriers in a unique situation with each different person. And because, there really isn't a cookie cutter kind of solution for what people need. So every single household, their exit plan was totally unique. We were fortunate for the most part, to be able to use Airbnb as permanent housing, believe it or not. A lot of the Airbnb, we were pulling things out of the sky to figure out how we're gonna, permanently house people. And there was a drop in Airbnb rentals. So we were able to negotiate with some of the landowners to be like, would you consider a permanent renter? If you're not getting business because the tourist industry is over right now, would you consider permanently housing one of our, clients? We can vouch for them. We'll pay for their security deposit. They're employed. They just, housing is hard right now. And we were able to work with some of these landowners through Airbnb who stopped renting out their Airbnbs to transfer them into permanent rentals. So that was awesome. Some folks, what they wanted was an RV. And so we made sure that we got RVs that worked, that they got their licenses straight, that they could register the car, that we had money to register the car, that the car could get smogged, that they had a plan of where they were going to safely park it, so that worked out for some people. We had one resident where we moved her back to Louisiana to be with her children, because at the end of the day, that's what was going to work for her. And for her need for stability in housing, was to just leave the Bay altogether. Yeah, every single situation was totally different. What we're known for in the village is building tiny houses. So a few of our folks we just built tiny houses for. That's what they wanted. So we just exited them into tiny homes, made sure they had a vehicle. For those folks, we bought them vehicles so they could attach the tiny houses that we built on trailers onto a brand new car. And so the idea was that we were not going to let people go back to the streets. This was going to be a step up to where they were coming from. And the ideal goal was to, find for people, normal permanent housing, right? An apartment, a house, something, but that just wasn't realistic. So we had to be creative with how we did stuff.
Thanks so much, Nita. I haven't heard the Airbnb specific strategy before, so I really appreciate, especially you sharing that. And I was going to ask it too, and you kind of answered me before I even had to ask, which I really appreciate, because I'm curious in working with them. This is for all of you, but one of the benefits I've heard from some communities that have been operating these non-congregate shelters is that some landlords who maybe would be more hesitant or unwilling to rent to folks that are working with the homeless response system are maybe a little bit more open to it when folks have been in temporary shelter, what looks like essentially housing for some period of time. So I'm curious if you all have found that, or if you're able to kind of frame the non-congregate shelter stays as housing, maybe even like provide kind of a reference for someone that they've been in housing for a period of time, whereas that wouldn't have been necessarily the case before, or other.
Yeah, we definitely had that experience. When some of our residents would try to advocate for themselves, for landlords, they got turned away. But if we did the advocating for them, even though we're unhoused ourselves, but because we have a title behind us and they don't know that we're looking for housing too, it's deep. The bias is so deep out there. But yeah, I think having that that level of advocacy, to not have to look for the housing themselves and to have a body basically be able to write a reference and vouch for somebody who did not have a rental history. I feel too the hotels gave people that 1 year of being able to claim that they were housed for a year. No one asked how much rent they paid, but I would tell our residents, yeah, but you've been here for a year. You're a resident. You have rights, right? So tell them that you've been here for a year and that you're just moving on to look for something better. So yeah, I think that definitely helped out.
Yeah, and I will say, I'm similar to Josh, and I can't speak too much to the housing side in the sense of the exits that we've had from our Project Room Key sites. But I do know that we have been able to exit a fair number of households into our permanent housing, as well as even temporary housing. But a lot of those permanent housing, we did use some of our housing security funds that we have here in the county to get people document ready. There's the fact that it costs money to get documents when you don't have any income or you have very little income. It is a challenge, and we definitely saw that as a challenge. So once those funds, we made some of those funds available and allowed people to get those documents without having to pay for those. It expedited our document readiness for sure. And then same with the Housing Authority gave us some mainstream vouchers to get into some of these permanent housing, and those mainstream vouchers really did actually get a lot of people out into those houses, and many of them have actually been able to get leased up. We're still working on a couple more as we transition out of these Project Room Key sites, but we have identified those clients who are ready and document ready and have vouchers in hand, and moving them to a shelter, keeping that same case manager. I think that's one thing that we have seen very beneficial, and we're really working on it, is making sure that we're not changing kind of the housing navigation services and housing locators and case managers that are signed with these clients that haven't yet leased up as we have to move out of these Project Room Key sites. So that way they can continue that work that they're doing and not have to start all over again and continue those relationships. I think that's going to be a huge benefit. So that way, if they do come to our shelter sites or congregate sites, they won't have to be there for very long.
Thanks, Lynnae.
It's really going to be so interesting to compare and contrast San Francisco to Oakland and Alameda County, because the COVID-19 pandemic, is exactly overlapped with the rollout of the Prop C funds in San Francisco. For those of you who aren't aware of that, this is a tax on companies that make $50 million or more a year in San Francisco that's bringing in about $360 million of targeted funding for homeless services in San Francisco. And because it was held up in the courts, we actually have about $700 million to spend in the first year. And most of that is going to go to an expansion of permanent supportive housing. So almost all the people in our shelter-in-place hotels are going to be able to move from that temporary non-congregate shelter into permanent housing. And it's because the voters of San Francisco got behind this tax, which any other county could, of course, do as well. So we have an opportunity to see another really interesting experiment where in San Francisco, we'll see the health benefits of people who moved into shelter in place, hopefully continuing to permanent housing. And then unfortunately, just across the bay, where Oakland hasn't been able to get the voters to get behind a proposition such as this, we'll be able to compare and contrast the health outcomes for this very similar population. And hopefully that argument will be strong enough so that everyone throughout the state of California can get behind moving money from the wealthy to people who have less so that they can all have a home.
Thanks, Josh. So I want to, I have a few more questions left for the panel before we take a break and then switch to some breakout, like some Q&A essentially, and some breakout conversations. So, you know, we've talked about the ways in which the non-congregate shelter has been able to support folks to get access to different healthcare services or the benefits it can have on health. We've talked about the housing piece as well a bit, but the third category that we had talked about is the ways in which non-congregate shelter can be utilized to ensure that we're serving the most vulnerable populations among folks experiencing homelessness. And a lot of this has come up, of course, in some of your answers to previous questions. But so I particularly want to ask ways in which, you know, your community or in your experience in non-congregate shelter you've been working with has been able to really ensure that the most vulnerable folks experiencing homelessness were being served through these non-congregate shelters. And like, for example, Josh, you mentioned that, you know, in San Francisco, you sought out people that were the most vulnerable. Jenny Lynn, you specifically mentioned, like, for example, folks who were, you know, able to kind of escape violent situations in one way or the other to come into shelters. So some of this has come up a bit, but I'm curious if they were both in terms of identifying and reaching folks and bringing them into the shelters, but then also the ways that you ensured that you were kind of able to connect, you know, needed services and resources to folks once they were in shelter. And like, how did you kind of ensure that that was happening, or, you know, prioritize certain populations as being most vulnerable?
Yeah, I can start. So our first non-congregate shelter originally, where we focused was at our large single adult shelter in Santa Rosa. It was a 213 bed shelter, and we knew we were going to need to reduce the capacity to ensure social distancing in the shelter site. So we originally started there, and we moved had people in that met all the high risk categories. And if they met multiple categories, we kind of triaged from that place and put them into our non-congregate shelter. From there, we then started looking to our encampments, and we started looking at our most overcrowded encampments. And then we went in utilizing the VI spit out, which is what our community uses as our triage tool. And given that, because the individuals in our Finley site, which was our tent site, you didn't necessarily need to meet the category of high risk of complications from COVID. That was really to alleviate the social distancing issues and so on and so forth that we were seeing in our encampments. And so that one we used the highest vulnerability in our most densely populated encampments. And we really did go and work with the people who are most at risk. And what we started seeing is once we were under operations, people started to seek us out, especially people who had never come into a service before. And it started to turn to a place that people felt was safe. They knew that they could get their services met. And we, about maybe a month and a half, 2 months into our operations, was when we started seeing an uptick among women escaping domestic violence, human trafficking, and sexual trafficking, those kind of things coming in off of the streets because they knew they could be safe. And so that was kind of the evolution of how we targeted it. And we started to talk to people who we had good relationships with in our encampments, but that we didn't have a place for them in our system to really be, except for housing. And this was a place to have them be in a safe place and captured for a little bit to then work on the housing piece with them. So we use the VI SPDAT and in the kind of in the unsheltered encampment population to help us triage the people with highest vulnerabilities.
Mr. Allen.
Not sure if you can hear me because my internet was getting a little unstable here
Yep.
up in the Sierra.
Yeah, we can hear you.
Okay, good. You know, so the prioritization process in San Francisco is kind of whack, honestly. So there was, you know, a bunch of people who had this fairly fixed series of diagnoses that somebody sitting in Atlanta decided was at risk for having bad outcomes from COVID. They got them prioritization into housing, including being over the age of 60, which is a good thing across the board. But there were a lot of really sick people experiencing homelessness who didn't qualify for the shelter-in-place housing. They could have had, for example, ongoing traumatic brain injury and under the age of 50, amphetamine addiction, all sorts of, you know, type 1 diabetes didn't qualify, but type 2 diabetes did. So it was, you know, a whole bunch of kind of, to me, almost hard to justify diagnoses. I mean, I understand the rationale behind it, but it was very hard at times to say to people who were very sick, no, you can't qualify for this housing. We have to leave you in the congregate shelter on the streets. So that was at times heartbreaking and very disappointing, and I'm sure much more disappointing for the people who are experiencing it than not for me. And it also gives us a chance to understand that housing, again, is such an important healthcare intervention, because for those people who didn't qualify for the housing, we could see that their poor health outcomes continue. So hopefully we can learn from this experience so we can readjust and find the prioritization to be more scientifically based.
Yeah, in Contra Costa County, we prioritized really based on our sickest populations. At the beginning, when first moving, and we had a lot of rooms to fill, we really just used the FEMA diagnoses. So it was pretty broad, and so we were able to kind of move people off the streets into the hotels. And then as the rooms started to become as a day-to-day availability, then we started to kind of look at a more stringent prioritization process that our medical director here at Healthcare for the Homeless kind of set those priorities. Those, you know, living with cancer, those with HIV, pregnancy, things like that were some of the number one prioritization, and then we went to some of the more COPD, those kind of chronic diseases.
But I want to just give props to folks in Coco County, because, you know, there have been lots of times when there's been decisions that have been made that some counties have been very strict about their decision making that didn't necessarily lean into the humanity of the opportunity. And across the board, I live just across the border in Alameda County, and just watching what you all have been doing has been so heartwarming, and just, you know, really thinking through how to perhaps push the envelope a little bit, but always trying to really attend to the humanity of the decisions. And it's been very wonderful to watch. Thank you.
Yeah, for us, we expanded the definition of vulnerable for us. So we included all forms of diabetes, sickle cell anemia, considering to the 80% of the population who's homeless in Oakland is Black, and that's a medical condition that specifically impacts Black folks, and a lot of folks do have it. We included women who are pregnant, and we also included families with small children. If anyone knows anything about small children, you know that a child cannot sit still. And expecting a child to sit still inside a car, inside a tent, to shelter in place during COVID is, we felt like that put the entire family in vulnerability. So we included small children under the age of 10. And we did a referral. It was someone from the Village, or someone from East Oakland Collective, or from Love and Justice in the Streets had to refer folks. All you needed to do was be able to check off one of the boxes, how that describe your vulnerability. And if you could check off a box and got a referral from one of the 3 organizations, then you qualified to come into the program. I think our biggest thing, our biggest setback was that we just didn't have enough capacity to take in more people. That we filled up our program into full capacity within 2 or 3 days. And we constantly had a waiting list. We had constantly had people trying to join the program. I think because we have very small restrictions when compared to, our friends in Alameda County or in the city, people had different experiences. And folks started referring, like, you need to check out what they're doing with the village because, you like the program. So we were overwhelmed with a very large waiting list that we never got to the end to.
Thanks, Nita. Yeah, that's a good, you mentioned a couple of things that I want to follow up on. I apologize, panelists. This question I didn't mention this to you ahead of time, but hopefully it's not completely surprising. But Nita, a few things. One that, there's limited capacity with any program, right, including non-congregate shelter. And by virtue of what the shelters have looked like, unless people are exiting to housing or for, other reasons, like a lot of people are staying in their rooms, throughout the duration. And so there isn't a lot of opening up. And you also, I appreciate you bringing up too, the fact that, you were saying in Alameda, but I think it's true in many, many communities, if not all, that, Black and Indigenous and other people of color are overrepresented in the homeless population. And so I did want to also ask the extent to which you were able to be intentional about like how both like the folks who are coming into non-congregate shelters in your community, like what the demographic breakdown was, like how that compared to your overall homeless population. So looking at it through that sort of equity lens, like how you were, if you were able to be intentional about folks coming in, but also to the extent that you were then using non-congregate shelter to connect folks to other services, like if you've been, able to look at how that breaks down as well in terms of race and other demographics that obviously are important from looking at like how we're equitably serving folks.
I have some data for you. Just quickly share that, the rates of African Americans among the people experiencing homelessness in San Francisco, about 34%, with the general population in San Francisco is only about 6%, 4 to 6%, was 6%. 4 years later, it's 4% because of all the African Americans who have to move out because of the high cost of housing. But among the shelter-in-place hotels, we had about a 40% African American rate. So we were even overrepresenting African Americans in the shelter-in-place. So we just continued to show, and throughout this conference, this has been stated over and over again, that homelessness is a result of institutional racism, and that it's our responsibility to fix that through finding ways to prioritize housing towards populations who've suffered from racism historically in this country. And we have to keep on that all the time because it is a huge, huge lift to try to roll back this historic wrong.
Yeah, thanks, Josh. And yeah, I didn't mention this when I was framing my question, but right, in addition to people of color, especially Black and Indigenous people being overrepresented in the homeless population, obviously we're all aware of the way that COVID-19 has disproportionately impacted those same populations of folks across the country too. So another reason to really try to be intentional in terms of the way in which non-congregate shelters are meant to be COVID response, part of the public health response too. So thanks, Josh.
Yeah, we're always mindful of equity with the work that we do. I'd say about 90%. So we were also overrepresenting, but about 90% of our residents were Black, African American descent. We had 4, I don't know the percentages of this, but the remaining 10 would be like, we had 4 households that were Native. We had a Hawaiian household, we had an Alaskan Inuit household, a Lakota household, and a household from El Salvador. We had 2 Southeast Asian households and 1 white household. And that was our breakdown in terms of looking at through a race lens.
Yeah. So I have just 2 more questions before we go to breakouts. The first is, we, especially in talking about, as we kind of shift from talking about these shelters being the ways in which you're able to connect to folks who are particularly vulnerable. And also, we've talked about trying to connect folks to housing and other services on an ongoing basis. I want to acknowledge that non-congregate sheltering is in general more expensive than like congregate sheltering, and especially when you're able to connect folks to services and provide people their own space in motels. And so this obviously has been a topic, the expense of these shelters, and obviously that factors really heavily into the sustainability of this type of sheltering. But as folks are we've all been talking about a lot of the benefits of non-congregate sheltering versus congregate, and so of course the questions come up like, is this the new way that our system should be operating, that we have not just in the context of a pandemic but in general have more of these non-congregate options? So would love to hear from some of y'all if you know like how either your program, your community has been having these conversations or messaging around this as far as, you know, the continuation or the sustainability of this type of this model of sheltering going forward once we're sort of past the public health response piece of it.
Yeah, I would say so. It is costly in some ways from an expensive standpoint, but when we look at cost impact, we want to look at also how much are we, you know, by not providing these services, it costs our community more, and there's so much data around it. And so when we build the community case for why we need to do these things, we look at those costs, and you know that's why we evaluated. Did we see a reduction in calls for service among our first responders and things of that sort? So we look at things from that perspective. What I think is a huge improved opportunity, and I think many communities are doing it, I know the state is putting money into this, was the Project Room Key to Project Home Key transition. By turning what has been a kind of captive audience of hotel owners willing to partner on this homelessness crisis and turning that into permanent supportive housing, we've been able to do that. We did this here locally at one of our motels. We turned a 104 unit motel into permanent supportive housing. And we're actually able to pay the landlord, you know, pass through some of our housing voucher money and our continuum of care funds to the landlord. So financially works from him from a private standpoint. He's able to afford the items that he needs to do to survive and to keep the property. And then we're able to create new permanent housing. I think this is, especially in a housing scarce place like California, and definitely here in the Bay Area, repurposing existing housing is the cheapest way to do it. We won't just be able to build our way. We have to repurpose what we already have. And so while it has been expensive to operate it as non-congregate shelter, I think that being able to then turn them into permanent supportive housing units also really makes sense and would be really helpful as well. And we see the community impact. But my argument always is, A, it's worth the investment, because if not, these people will die on our streets and have been dying on our streets. And B, the community cost is far more when you actually calculate, you know, the criminal justice system, the emergency room visits, the you know, ambulance trips, the court costs, all of those things are all costing us all of that money. It's just not in a budget line item that people can see when they see something like a non-congregate shelter budget. So I think although it's expensive, it's far less than doing nothing about homelessness.
Thanks, Jaylyn. Anyone want to add anything to it? Yeah, Nita, go ahead.
I would say that why didn't we do this earlier? Yeah, this it's unfortunate that it took a pandemic for an intervention of this scale and the urgency of this intervention. I know what we've been saying in Oakland is that we have seen a total lack of urgency from our political leaders or elected officials to treat homelessness as the emergency that it is. And it took a pandemic for that urgency to finally be manifested and for the scale of housing that we needed to finally happen. And I hope that with the pandemic dying down, that urgency doesn't die with it, that the urgency to house people continues. I know with us, it was very expensive to run this program. I don't know how we did it, to tell you the truth. We literally were shooting from the hip the entire year. I don't know how we did it. But one thing we did realize is like, dang, we could have just bought a hotel with the amount of money it took to run this damn thing. So I know one thing that we're looking towards in the future is about purchasing some kind of facility that would allow us to house, you know, a couple of dozen households. One thing that it also informed, just seeing the kind of, just within the first couple weeks of people being housed, the kind of transformations that we saw in people just in those first 2 weeks, you know, let us, you know, informed us that, like, you know, even if this was a temporary hotel program, if this was a temporary hotel voucher program, something like this would be really good for folks. And so we actually created a hotel voucher program that was informed by our COVID program called Streetcation. with the idea that, you know, people who work, folks middle class, they need a vacation from their daily grind. People who live in the streets need a vacation from the streets for the same exact reasons, mental health reasons, a breath of fresh air, you know, just getting a moment of respite. And so that was something that came out of this, was that, you know, this is a very important intervention, both permanently as a long-term, as well as just emergency, you know, intervention. You know, we see folks dealing with domestic violence in the encampment they're living with. Like they're trying to get away from violence in the encampment, but can't. So go in a hotel, figure out your next, you know, your next steps. We'll help you figure that out. With folks who want to kick their habit. One thing that happens a lot is like, today I might want to kick my habit and I go to Cherry Hill to detox and they have no beds. Tomorrow, maybe I don't want to kick my habit. So the idea would be like, well, you want to kick your habit. There's no beds in Cherry Hill for you to detox. There's no openings in any of the rehab centers. So come in a hotel for a few days and let's work on getting you into a detox so that you can go straight to detox. Because that moment when someone has that clarity, that desire to change, you need to jump on it. And over again, we see people want to quit. There are no beds. So why quit? So we want to try to end that whole situation. But yeah.
Thanks, Nita. And I appreciate between Jenny Lynn, you and Nita's responses, I think we got a good sort of balance of, it's not actually like, maybe the expense literally of just this program, if you're looking at it as in a vacuum, is high, but when you compare across the savings and also just the, you know, benefits to human life, which is worth considering as part of the factors, obviously, although not everyone sees it as part of the equation. That's one way to look at it, that it is actually, you know, an effective, a cost-effective intervention. And also, Nita, the way that you kind of phrase some of the ways that you could sort of continue some of the elements, even if not the exact program exactly as it's working. So I'm going to ask one more question that's a bit meant to be sort of a little more of like rapid fire before we go into breakouts. And that's just, as we're thinking about, you know, the fact that these non-congregate shelter programs look different in every places, we've talked about different types of benefits and the ways that they, you know, kind of manifest in across the folks who are able to get into the non-congregate shelter. If you could each give us in as few words as possible what you think are the 2 or 3 most essential elements of non-congregate shelter that sort of result in the benefits that you've seen.
Yeah, I'll go quick. A linkage to housing. If there's one thing that we would have done differently, it would have been a stronger linkage to our housing voucher program, because that would have been huge. And then the second would be on-site medical and supportive services for the individuals, absolutely critical in all of what we do. And then the last would be community outreach and community kind of engagement, like having the individuals that are living in the site, as well as the neighbors, get to know each other, demystify what people think homelessness is and it isn't. So those would be my 3 things.
Great, thanks, Jenny.
I'll go. First, dignity. A home is a place you can have dignity. And secondly, the one underlying condition that every homeless person I've ever cared for is experiencing trauma. And the treatment of trauma is safety. And a home provides safety. So it's very different from a congregate shelter when you have a place you can close the door and lock it.
Mm-hmm. Yeah. Thanks, Josh. Great. Lynnae?
Yeah, I mean, I would probably mimic a lot of what they're saying. I think medical and behavioral health services on site. I also think making sure that everyone sees a medical provider or a behavioral health provider at some point during their stay, if not right within the first 2 weeks, and just saying, hey, we're here. If you don't need me today, that's fine, but here's how to get me any other day. So I think that was really important we saw. And then definitely the safety piece that Josh is speaking of. Oh, I think this opportunity gets a lot of our clients off of the streets who don't feel safe in a congregate setting or in a shelter setting. So I would say those 2 for sure.
Thanks, Lynnae. And then Nita, last but not least, you have 2 or 3 of the most essential pieces you think should be part of any non-congregate shelter.
Definitely wraparound services on site. The exit program, having something that's set with the exit program. And having a culture where residents are treated like, you know, if they're adults, treated like adults. What I see happens a lot is unhoused people, we get treated like we're children. or we get treated as if we're criminals. And to leave those two biases out of any program, congregated or not, is crucial, I think, for there to be cohesion with the residents and the staff.
Thank you so much. Thank you all so much for your really great responses and really willing to share so much with all of us. We'll have, after the breakouts, we'll bring you back and I'm sure we'll subject you to one final question before we break. But really appreciate you all sharing so much during this panel. It's really fantastic to have all four of you here and to have so much time to be able to hear from you about this. So we are going to, I'm going to share my screen one more time just for really quick. We're going to switch to breakout rooms briefly. So we're going to have about 15 minutes in breakout rooms. And as I mentioned earlier, our panelists have very graciously agreed to be part of these breakout rooms, and each one will also have me or one of my colleagues, Maddie and Alicia, to help kind of facilitate the conversation. But we have about 15 minutes, 10 or 15 minutes in each one. It's basically an opportunity for you to, ask follow-up questions if you have them for any of our panelists. They shared a lot, but you may have, I'm sure you have additional questions for them. And when we come back, we'll do a really quick debrief and a closing question with the panelists. So in order to, you're able to select your breakout room. We have 3 different options for folks, and they'll be pretty small discussions. So you'll be able to ask your questions. So we have a rehousing one where Lynnae and I will be in there. We have a health specific one where Josh and my colleague Alicia will be. And then Jenny Lynn will be in the group with vulnerable populations with my co-moderator Maddie and Nita, whichever of those rooms you'd like to go in, feel free to jump in. So for all of you who are attending, all of you participants, you can click the breakout room at the bottom as soon as they're ready. They should be ready, and then you'll be able to select which one you want to join, and you'll be able to go right into that group. So you can ask follow-up questions of the panelists, or if you have information that you'd like to share with one another, we would really welcome that too. We know a lot of you have been doing work in non-congregate shelters as well. So if you'd like to share with your group, welcome that as well in this bit of time. So I'll leave this up until just so people can see the instructions. So feel free to click breakout rooms at the bottom of your Zoom window and select the one that you would like to join, and you should be able to connect over there. If you're having trouble or need help, you can let us know in the chat.
Hi, I'm having trouble getting into the breakout room.
Just which room were you?
It was rehousing.
Rehousing. And what's your name, ma'am?
Irma Barden.
Okay. 1 second, stand by.
Thank you.
You're welcome.
Hi, Jillian and Maddie asked me if I could come out here and just ask that the rooms be closed at 2:50.
Sure, no problem. We'll close them at 2:50.
All right, thank you so much.
Okay, thank you.
Thanks.
All right. Hi, everyone. I think we're waiting for the other group, the other breakout group. They're clinging to their breakout group longer than we did. I think they're making their way back. All right. So in the last nine minutes we have, I just want to, I'm encouraging folks in the chat, if you wanted to share something that you learned in that breakout group or something that was surprising to you, something that stood out, please do, just for the benefit of the folks that were in the other group. And I think I'm going to turn it over to, well, before I do this, I'm going to turn it over to my colleague, Maddie, to sort of close us out while you're putting your responses in the chat, if you'd like to. I just want to thank all of you for being here still, for participating in this panel. I know it's the last afternoon of a really great big conference, and so I really appreciate you all joining us for this panel and sticking around till the very end. 2 hours is a long time, especially any day. It's a long time to stay on a Zoom meeting, so I really appreciate it. And before I pass it over to Maddie, I just want to personally say thank you so much to all 4 of our panelists. Really appreciate the time that you devoted and all the work that you've been doing in your communities and being willing to be on today with us for these 2 hours to share. Really, really appreciate it. It was great to hear from all of you. So with that, I'm going to hand it over to Maddie, who's going to walk us through our kind of final debrief and
Great.
close us.
Would you mind putting the slide deck back up, Jillian?
Yep, sorry, I forgot that I hadn't done that. There you go.
Okay, great. So we're debriefing very quickly. So if folks can put it in the chat, what is one thing that stood out to you from the breakout room discussion? And we've got a few enough folks if maybe some of our panelists wanted to highlight anything that had come out from their breakout rooms or anything of note. What about you, Jillian? Did anything good happen in your breakout room?
Not to put it, I'm not going to put a value judgment on whether it was good or bad. No, I'll just say I just really appreciated that folks, were all willing to kind of introduce themselves. People are coming from different places. And I think one thing that's nice on the housing front is that the sort of challenge of even with all the benefits of folks being in a non-congregate shelter for a long time and all the benefits that comes with in terms of, you know, being able to get folks document ready and just getting to know people over time and sort of allowing folks to stabilize, that there's still no easy answer to get everyone moved into housing. And so I think it's sometimes helpful to hear that from other communities, that the question still of, okay, but we still have folks who need permanent sort of housing and we don't have enough stock, and sort of acknowledging that those challenges are still there and trying to figure out ways to work through them, I think is always helpful to hear from other folks. So appreciate folks that brought that up.
Yeah. We have someone in the chat sharing that it was lovely to hear about neighbors coming around and becoming supporters and volunteers. That is definitely something that's always coming up in this space, how to get around the NIMBYism. And I think Jenny Lynn really highlighted that. Sometimes people, they get used to it, and then they're some of your greatest supporters. Other folks are saying loved the Airbnb idea, as well as the reminder of the way to address traumas through safety. I know our breakout room talked quite a bit about harm reduction approaches and how those have been beneficial in non-congregate shelter, and hoping to bring those forward into the rest of life after the pandemic has ended. So folks can feel free to continue to share any key takeaways from the breakout sessions, but I think we're going to go to our next slide. And we've also have a poll. So we'll let our Housing California friends share the poll with you guys. But the question is, will your community have non-congregate shelters available after Project Room Key ends? So we'll give it a second. Oh, there it is. And we'll give folks about 1 minute to respond. I know we've seen a lot of communities leaving their Project Room Key open for a longer period of time to give folks a little bit more runway in order to get into their housing. But with Project Home Key, a lot of folks have thought about rehabilitating shelters and motels and hotels into shelters, as well as thinking about new things like sanctioned encampments and safe parking as pliable models in communities that might have resisted it before the pandemic. So I think we can close the poll and share the results, please. All right, so it looks like about 55% of folks say yes, 9% are saying no, and then there's a good chunk of folks who are not sure. So maybe that's the same chunk of folks who didn't know what non-congregate shelter was before today's presentation, and now you know the keywords to Google. So that's great. We love non-congregate shelter. Okay, so we have just one final kind of rapid fire question for the panelists, and that question is, I lost the question. I will pull it up in just 1 second. What is one piece of practical advice that you would give to communities that are standing up a non-congregate shelter for the first time? And anybody or everybody could weigh in from the panelists.
I'll just quickly say, look at it as a public-private partnership. From the private sector, this benefits them, especially when our hotels were hurting during the pandemic with the lack of travel and so on and so forth. You know, this was a way for some of them to stay alive. And when we converted our, our 104-unit motel into permanent supportive housing a few years ago, it was a public-private partnership. It was us utilizing funds that we couldn't utilize because we couldn't find the housing to be able to then make a private partnership work. So sometimes thinking of it, not just from our nonprofit or public sector lens, but looking at it from the private partners lens, you can get more done and you can find more collaborative opportunities to increase your housing stock in your community. So sometimes look at it not just from our public sector lens, see how it benefits them and maybe use that as a way to attract more private partners to this helping to solve homelessness.
And I'll say that we often talk about competing life priorities, that people experiencing homelessness don't have time really to do so much of the things that some of us housed people take for granted. When someone moves indoors, you get a small window where there's actually some excess time that wasn't expected to be there in your day, and use that time to provide some medical services so that people who have otherwise not been able to find that as a priority in their lives can take that as a priority and actually get some benefit for their long-term health needs.
I would say two things. One, don't do it alone. Reach out to your community, whatever that looks like, and be creative about what does support services look like. Not everything is, especially if you're dealing with a population, a particular demographic, make sure you're being culturally relevant. Therapy doesn't look the same for everybody. In fact, many communities of color kind of reject therapy because it's very intrusive to us. So, when you're thinking about what people need therapy, think about, what are some alternatives to therapy? How can we use artist therapy? How can we use a field trip out to the woods for therapy? Just be creative with how you do stuff and know that you don't have to do it alone. The more partners you have at the table helping you, the better for you and also the better for your residents. And then to really utilize this time with your residents to really encourage them and help them get out of the mind state that living on the streets has created. There's a whole kind of, re-education, reprogramming of folks who've been chronically homeless. Life on the streets is definitely not your regular society. It's a society outside of itself. And if people have been there long enough, getting and holding on to permanent housing is really difficult. Like I spoke about earlier, there's a freedom that comes with living in the streets. Along with all the bad stuff, there's some good stuff. And so being able to utilize this time to really think about how do we support folks to transition into permanent housing and holding on to it once they get there.
Hey, Lynnae, any 20-second advice?
Yeah, 20 seconds. I mean, I think one thing we've learned a lot being a county with a new non-congregate setting is getting consumer input. Really asking them what makes you feel safe here, what would you like to see, what would get you indoors. Those kind of things are really important because we think we know as program coordinators and developers, and I think sometimes we're not getting enough of what is truly the need and what would make people feel safe and what brings people inside.
Great, thanks. Well, thank you to everybody for joining us today. Thank you to our panelists for all that they said and for all of the transparency and talking about the programs and the benefits and the downsides and all of those. On the screen, we've got all of the emails, but Housing California also has the slide deck. So that will be posted soon if you need to reference it again. definitely feel free to reach out to us, and we hope that you have a good rest of your day. Thanks everybody for joining.
Thanks all. Take care.
Thank you.